Good afternoon, everyone. Welcome to Senate Finance. Today is Wednesday, February 7th. We only have two bills today, which sounds exciting, except one of them has 35 witnesses. So we have a rule. If we have more than 30 witnesses, everyone gets 1 minute, except the sponsor, who will get all the time that she needs. So we're going to begin, and I know I have some elected officials, and you will be on panel 2. So we give our sponsor time to set up the bill. So you won't be very long, counting executives, but thank you for being here. So Senator Gall, would you like to start? So the order of the bills is Senate Bill 388 and then Senate Bill 487. Thank you.
I think I have my panel too, Madam Chair.
Jane Horvath and Andrew York.
Sure, that works. Thank you. Good afternoon, Madam Chair, members of the committee. For the record, Senator Dawn Guile, District 33, here to present Senate Bill 388, Prescription Drug Affordability Board, Authority for Upper Payment Limits and Funding. And I thank you for the opportunity to present this bill. This legislation builds on the 2019 law passed under the leadership of this committee, especially then lead sponsor Vice Chair Klossmeyer, which created the nation's first Prescription Drug Affordability Board. Unfortunately, despite this progress, the skyrocketing cost of prescription drugs remains a growing issue in our state, one that touches lives in each of our districts, with a staggering 1 in 3 Marylanders reporting that they have skipped a dose, rationed medication, or left a prescription at the pharmacy counter due to cost. Even those who can afford their medications are left paying a hidden prescription drug tax. As insurance premiums or our tax dollars, we are all hurt by the high cost of prescription drugs. As you will hear from my fellow panelists, the Maryland Health Benefit Exchange reports that prescription drugs presented nearly 30% of the total spending for privately insured markets in Maryland in 2020. Similar numbers were shared by CareFirst, Blue Cross Blue Shield in 2017, indicating that this is a long-standing concern and one that is felt throughout the health insurance market. You will also hear directly from our local leaders on the next panel, who can attest to how high prescription drug costs burden our government budgets, limiting resources for other public services. Most importantly, today you'll hear from patients who have suffered because of the costs of their medications. Senate Bill 388, which would expand the authority of our Prescription Drug Affordability Board to allow it to establish statewide upper payment limits for all Marylanders, is an opportunity to provide directly relief to our residents and to ensure much needed cost containment for our state. With little in the form of existing regulation, the prescription drug pricing system operates in dysfunction and complexity, prioritizing profits over people. Prices regularly rise faster than the rate of inflation, with much of our increased spending coming from price hikes on existing medications rather than on the introduction of innovative products. In 2024 alone, a year in which we were only in the early days of February, drug companies raised the prices of over 775 prescription drugs. While pharmaceutical corporations claim that these prices are needed to offset the costs of research and development, a recent report from Public Citizen, which you will hear more from a later witness, shows that pharmaceutical manufacturers routinely invest billions more in self-enriching activities than on innovation. Clearly, innovation is not the driving factor of drug prices. Additionally, you may hear in opposition testimony that this issue is solely the fault of other members of the supply chain, like PBMs or insurers who absorb rebates before they make it to consumers. Thankfully, our Prescription Drug Affordability Board is uniquely equipped to address this concern, as it is tasked with reviewing the entirety of the supply chain, ensuring that its decisions take a multitude of economic factors into account. Currently, our board has been granted the authority to address the cost of prescription drugs for only our state and local governments, pending the approval of the Legislative Policy Committee, action that we anticipate will be taken in the coming months. Today's legislation would bring the board closer to what was envisioned as it was introduced in 2019, If passed, Senate Bill 388 would grant our board the authority to examine high-cost drugs and establish statewide upper payment limits on what all Maryland patients and payers would pay, allowing our board to operate in a similar fashion to existing public utility commissions and much like our nation-leading HSCRC, which sets hospital rates. Since the law's passage, the board has done considerable work to build the necessary infrastructure for a novel state agency, despite years of obstruction from the previous administration. Much of the work that the Prescription Drug Affordability Board has already done to establish a process for cost review and determinations will translate easily to a statewide upper payment limit mechanism. When reviewing a prescription drug, the board will consider a broad range of economic factors, including allowing pharmaceutical manufacturers to justify existing drug prices. When an appropriate rate is determined, the upper payment limit will apply to all purchasers and payer reimbursements in Maryland, eliminating the need for the rebate process and ensuring that lower costs benefit consumers. Contrary to what you may hear, these upper payment limits will not impede innovation or access to life-saving medication. As I mentioned before, while drug corporations claim to need these staggering prices to fund research on new prescription drugs, they do not actively prioritize that effort now, spending considerably more on executive pay, advertising, stock buybacks, and political contributions. The industry has even put considerable money towards funding patient advocacy groups, often for rare diseases, which in turn lobby against reforms to the industry. Additionally, while the drug manufacturers like to threaten limited access if an upper payment limit is established, countless examples of their sales in countries with rate-setting authorities proves otherwise. Maryland is additionally protected by robust consumer protection laws, which prevent advertising without intent to sell and withholding supply for purposes of raising prices. With broad regional and national advertising markets, this would make refusal of sale difficult. And while I applaud our Prescription Drug Affordability Board for its work so far, the truth remains that it can currently do little to help Maryland patients directly. Too many of our families and neighbors have been faced with the impossible decision of choosing between the medication they need and their economic stability. By granting the board this expanded authority with the requirement that it again have its plan approved by the Legislative Policy Committee, we are ensuring that the state is well positioned to act swiftly to address costs more broadly following completion of this pilot phase, rather than forcing Maryland patients to wait yet another year to see relief. By expanding the board's authority, Maryland can join the ranks of Colorado, Minnesota, and Washington states, which have all created prescription drug affordability boards with full statewide upper payment limit authority. This session, we have the opportunity to help Marylanders struggling to afford the medications that they need. It is time we insist that patients are put over profits because drugs don't work if people can't afford them. And I respectfully request a favorable report on Senate Bill 388. Thank you, Madam Chair.
Thank you, Senator. Before Jane testifies, I want to welcome to our committee Senator McCray. He's here from Budget and Tax because we're jointly assigned. So thank you, Senator McCray. Jane, would you like to go next?
Thank you, Madam Chair and members of the committee for the opportunity to talk to you today a bit about S 388 and statewide upper payment limits in particular. I'm Jane Horvath of Horvath Health Policy. I do consulting with policymakers around the country on drug cost containment and statewide upper payment limits in particular. So I basically wanted to really talk about what a UPL is, but a UPL is basically healthcare rate setting. And Maryland has a history of this going all the way back to the all-payer hospital rate setting system that you all created years ago now. A UPL consolidates the state marketplace to create greater leverage with manufacturers concerning statewide UPLs. A manufacturer is not going to walk away from the entire market of Maryland, and they don't walk away from the entire markets in the EU, the UK, China, Japan, Canada, and other countries where they do rate setting, just like this would be. UPLs improve manufacturer access to the market and patient access to the manufacturer's product. UPLs can correct for the problems of the PBM and manufacturers clashing and competing business models that harm the patients and drive up healthcare costs. Thank you.
Jane, where did you come from today? Did you fly in from another state?
No, not today. I live in University Park.
Okay, so we're lucky to have you here locally. But because you're a national consultant, do you have anything else you would like to add that the minute didn't allow you to add? Or you,
Yes, but I guess the one point I would say is that in my view, actually creating state and local government UPLs is harder. You know, you have less market leverage. For sure, you have less market leverage. You have a product in the state potentially at two different prices, or you're going to have to work through your PBM contracts and get rebates. It's just much harder to get the benefit that of an upper payment limit in that context to the patient at the point of service, whereas a statewide would do that.
thank you for that. And next we have Andrew York, who is the Executive Director of the Prescription Affordability Board. So
Great. Thank you, Madam Chair, members of the committee. We've submitted a letter of information describing our work for this year. We'd like to thank the committee for your continued support. And we are very excited to continue to work to make prescription drugs more affordable for Marylanders. And I wanted to be here to be available to answer any technical questions you may have about our work. Thank you.
do I have questions for Mr. York? When I looked up your testimony, it just said oral, so you also have a.
Oh,
you
excuse
also-
me. It was submitted on behalf of our team under Christina Shackley. Sorry about that.
Thank you. That's where I'll
Excuse me.
find it.
Sorry about that.
Senator Hershey?
Thank you, Madam Chair. I guess, Andrew, let me start with you, if you don't mind, please. On page 6 of this bill, it strikes all the language about a December 1st, 2026 report that is due to Senate Finance Committee and HGO regarding this. In striking all of that, does that mean that this report's already been completed and you've provided those results to the bill sponsor and the advocates of this bill?
No, that report has not been drafted. We plan to draft it by that deadline.
You plan to draft it by 2026,
That's by that deadline, yes.
but if this bill strikes it, it means that you don't have to do it. Or I mean, I guess it means an assumption has already been made that your report is not necessary for the ability to start setting upper payment limits can be determined already.
Our board intends to follow the process that's laid out in our current legislation.
I just want to make sure.
Yep.
Current legislation says you'll have it done by December 1st, 2026. If this
Okay.
legislation, the way this bill is passed, strikes all that, essentially means that, are you saying you'll still continue to do it or you won't do it anymore?
I mean, I think we're trying to not provide hypotheticals on this specific issue, but I think as we currently plan to draft that report.
Okay. Can you have defined affordability challenge? That's been used in the bill previous and currently, that you are to evaluate prescription drug products in the state that the board determines has led or will lead to an affordability challenge. What does that mean?
So our cost review regulations have been published, and what we've done is laid out a number of different metrics. So we look at utilization to the health system as a whole, utilization to the payers, utilization and costs specifically to the patient. I think any of those could be criteria for determining if the drug's unaffordable.
So does it have to do anything with the affordability of a drug at the time a consumer purchases it at the pharmacy?
Our current cost review intends to account for patient out-of-pocket costs, yes. And we also want to get patient feedback on their personal experience as well.
Okay. Jane, if you will, you mentioned that you've been in other states. Have you worked with Colorado on this?
A bit, yes.
A bit. They're in a sense ahead of us in where they
Yes.
are. They're already starting to utilize the upper payment limits. What have you found from analyzing that state and seeing how progress is going there?
So they're moving ahead very quickly. They started work under a legislative sunset, so they really had to hit the ground running. It's it's very complicated. It's hard. This work is hard. So, it takes a while for people to get their, their sea legs about them on this work, but they are actually at the end of this month going to be reviewing their second drug in terms of looking at affordability. And I believe that's an HIV product. And they did finish last month in looking at Trikafta, which is a cystic fibrosis drug, and made a determination about affordability on that product, basically.
And that determination was to not go forward with it being on the upper payment level schedule,
They
right?
determined that that was not an affordability challenge to consumers
Right.
because the manufacturer puts about $100,000 toward everybody's copay.
There were also concerns about accessibility with that drug, right? That was what the consumers came back and they said they were concerned that if payment limits were set on that there would be accessibility problems.
Yeah, because the manufacturer would refuse to sell.
But you testified earlier that manufacturers weren't going to get out of states.
I
if we-
don't believe they will.
So I'm confused then. Colorado decides not to go forward with a drug with the UPI because of accessibility concerns. But now you're telling this committee that you don't believe that they would do that.
Yes.
And what's that based on?
Well, it's based at looking at Europe and the other countries. It's based on,
Other states?
so if I just need to digress for a second. So, a well contemplated, well executed upper payment limit is going to improve a manufacturer's market. So people who can't afford to get Trikafta because it is too expensive, and there are health plans in Colorado, 10 of them, I believe, that will not cover the product. Now, there are therapeutic alternates that people are getting on those plans, but they've made a decision not to cover this product, which tells me there's an affordability problem with the product. If the plan won't cover it, will only cover older products. And Trikafta is an excellent product. I mean, it's really important to people. So yes, I do not believe that they would boycott if the UPL actually increased accessibility and sales in the state of Maryland. A UPL should do both, really improve the manufacturer's market access in the state and improve patient access to the product. And that involves doing rate setting and hitting that sweet spot.
Part of the consideration for a UPL is that the board needs to determine that it demonstrates savings to the state or local governments. What does that mean?
Under the current law, well, I think it means that they're going to set an upper payment limit on a product where they pay, I don't know, $100, and the UPL is going to be 70, right? And so you can just calculate the difference. And if they execute through their PBM contracts, that should be pretty easy to do.
Yeah, I'm just trying to determine how that affects the consumer. It doesn't say anything about it will drive down costs to the consumers. And there's a lot of consumers here that think that this legislation will drive down their out of pocket expenses, but that's not even part of the bill here. That's not even a concern. The concern is that it demonstrates savings to the state or local government.
This is the current law.
Right.
Yes.
Now, this
And-
is
and-
I'm sorry, this is but this is the language in this bill.
Blanking on what. it
Page
is.
7, middle of the page.
Do you have it?
Andrew, you want to help out here, if you don't mind?
Under our current legislation, out-of-pocket costs, for state and local government, the plan designs have kind of moderations on out-of-pocket costs. So
Right.
most of the savings will be to the state and local government because Medicaid has a nominal copayment, and then our employee health plan has a very generous
This is the existing law.
copay as well.
No, this is an additional thing.
Right, so again, as you have a number of people that have gotten behind this legislation that believe that their out-of-pocket prescription drug costs are going to go down. Again, I don't see that anywhere in the bill. It talks specifically about savings to the states and local government, as I suggested. How does that translate back to the consumer?
Under our current legislation, it's limited to state and local government, so it is primarily a savings to the state. Again, there's limited patient cost sharing under those current plans.
So not to, again, we're not seeing, in a sense, you're saying we would have to rely on the government, state or local government, achieving some type of savings and finding some way to pass that down to consumers.
Sorry, I think if it was for plans that didn't have a flat copay structure, then you would create a mechanism to make sure that out-of-pocket costs are adjusted. In our current legislation, we're working with plans that have a flat copay structure, so it's difficult to make sure to pass any of those.
Yeah.
To change that structure.
And this might be a question for the next board. Would be interested to hear how some of our elected officials would plan on passing those savings down to consumers. But I think that, again, there's a little bit that's somewhat disingenuous about the narrative that goes on with this legislation. And again, a number of people here think that their out-of-pocket expenses will decrease. I do want to, Jane, if you don't mind, there was a article from a representative in Colorado who has been dealing with this. And her statement was, in theory, the board's goal is to make expensive medicines more accessible. But though that can create great headlines for some politicians, the concern in rural areas is it could impose even more obstacles to access life-saving medicines. And in your work with Colorado, you don't believe that that's accurate?
That's a really great point that you bring up. Rural counties, rural areas are often served by independent pharmacies as opposed to the chains that are so prevalent in our urban areas. So independent pharmacists have a very hard time. A lot of them have gone out of business because they typically get underpaid. So PBMs and insurers pay based on sort of national average cost to buy and stock a drug. And I think with a UPL in a state, you don't have to use national averages to sort of figure out what pharmacies are paying for their products. The UPL is the acquisition cost. And I think that this is going to be a benefit to independent pharmacists who serve rural areas far more than CVS does. So I think it'll actually strengthen their businesses and strengthen service in rural areas. And then also in urban areas that are underserved where CVS and Walgreens don't go. That is my opinion.
Yeah, no, I appreciate that. I would just say, it looks like the representative from Colorado disagrees with that, but
Right.
she's on the ground there and might have a little bit more access to where this is going. But Madam Chair, I'll be done for a little while. Thank you.
Thank you, Senator Hershey. I was about to ask you to be done for a little while. Thank you. Senator Lamb.
Sure. Thank you, Madam Chair. I do want to pick up on a point that Senator Hershey was making, though, that at the end of the day, who we're hearing from are our constituents, and those are our patients. And I think it's important to bear in mind that at the end of the day, they're the ones that need to see lower prescription drug costs. And what I want to pick up on is how can we ensure that having these upper payment limits results in actual individual patient level relief?
Do you want to take it?
Sure, go ahead.
Okay. So I mean, I can't speak to everything that's going on in this bill, but I think it's incumbent on the board to work really closely with health plans in the state, including employer plans, to get them to, when a drug has a UPL, to modify how they're putting the drug on the formulary and the cost sharing that they require of patients. Because that's, in my view, again, if a plan puts a drug on a really high cost sharing tier where it's costing the patient a lot of money to get that drug from the pharmacy, that indicates that there's a cost management problem right away to me. So if a plan's not covering a drug, if it has a 20 or 30% cost share, co-insurance on it, that's a problem. That's a problem for the health plan and a problem for the patient. And a UPL should be working to straighten that out. And I think, you know, the legislators such as yourself, if that is not happening, you know, somebody needs to talk about that. I think ultimately you could change the bill too, to talk about demonstrating directly to consumers. Colorado has a provision, for instance, where health plans have to report to the Commissioner of Insurance on how their savings are used with a focus on consumers. So they have to report annually on how they apply those UPL savings, which could be to premiums or out-of-pocket costs.
Right. And as a physician, you know, I want to keep the patient focus in mind. At the end of the day, those are the folks that are paying this. But does the board, I guess maybe this is a question to Mr. York, does the board have the power to compel a carrier to put in restrictions or ensure that those savings are passed along to the consumer, to the patient after an upper payment limit is put in?
So our board has made it very clear that patient out-of-pocket costs and patient experience is their top priority. And we do hear from a number of Maryland patients that they can't afford their prescription drugs. Most of those patients are not going to be patients on medical, the Medicaid program or state employees because of how generous that patient out-of-pocket cost coverage is. So just in terms of our current authority, is not as relevant as it is in the commercial sector in Maryland. I think just one other, but I know that's kind of a difficult. So
the answer to the question is no.
For state and local government under our current authority, I don't want to say it's not a relevant factor, but it's a flat copay program where the copay amount would not, it's a flat nominal amount. So our existing work is primarily to save taxpayer dollars under our current authority. The board prioritizes out-of-pocket costs for patients, but everyone is paying $5 or $1, right? I mean, that's an exaggeration, but everyone has a very nominal copay for the two programs that we can regulate, which is the employee health plans, and the state employee health plan is a very generous health plan. So we have very low cost sharing for state employees, and then same thing for Medicaid. It's a nominal out-of-pocket cost for patients. That's different than the full state. So it would become an issue under if you had a broadened scope.
So do you need any additional authority or different authority to make this work in the private carrier space?
We only have the authority to set upper payment limits for state and local government now. So that's
you're right.
that's what
Okay.
like when I'm giving my answers, it's always in the context of we can set upper payment limits for Medicaid, state employee, and local health plans, employee health plans.
Yeah, and to add, the legislation that we have, it specifies that the drug payment rate established by the board is to apply throughout the supply and financing chain, including pharmacy insurer transactions, pharmacy consumer transactions, insurer consumer transactions, PBM insurer transactions, and wholesaler pharmacy transactions for entities operating in the state. Thus, a consumer cannot be charged more than the payment rate at the pharmacy counter, and a health plan cannot set copays or co-insurance on amounts greater than the reimbursement amount. Did you want to expand any more on that?
Well, I wanted to apologize for my brain freeze, number one. But yes, so a person in their deductible, a person who has a co-insurance applied is going to see the effect of an upper payment limit immediately, right? Because if it's 20% of $100 or 20% of $80, right, that's right there. The thing that Annie was talking about is sometimes there's a tier of $75 where you pay or $50. That's harder to evaluate, but patient's going to see it at the point of service right away under those two circumstances. And uninsured also, uninsured people.
Got it. Okay. So I agree that there are some and oftentimes many drugs that are overpriced, but looking through the testimony that's been submitted here, I see oppositional testimony from the Michael J. Fox Association, the Maryland Association of Clinical Oncology, who are all opposed to the bill. Do you have any sense why they may be opposed?
Do you want to, or should I?
It's okay. Go ahead.
So I think it really has to do with this whole idea of orphan drugs. So the industry itself has thankfully gotten very involved in the orphan drug space. And those are drugs for people with rare diseases who, prior to a lot of federal policy making to incentivize the industry to go to this place, they really didn't have a lot of hope for a lot of options, because a rare disease is defined as something that affects under 200,000 people in the US. And it's hard to make a profit off of that. or it used to be hard to make a profit off that, shall we say. So, I mean, the industry has really figured out a way to make a very high profit off of these things, but they do continue to tell patient organizations and things that, the orphan drug development will dry up and that there won't be any access, any R&D or innovation in this space anymore. And I actually find that very hard to believe. I recently just wrote a whole short paper on the business model of this. And these products are actually more lucrative than the non-orphan drugs, the big blockbusters that we used to know about, cardiovascular diseases and diabetes and things like that, far more. You probably are familiar with Humira, yes? So that started out as an orphan drug. And when it patent expired last year, it was pulling in $20 billion a year globally. Trikafta, which is an orphan drug and serves only the orphan population. It's not like Humira serving all different indications. That's the third best-selling drug in the world. And it only treats people with cystic fibrosis, and Vertex won't even sell in low-income countries where people can't afford their price. So not even everybody in the world with CF is on Trikafta, and yet it is the third best-selling drug in the world.
And I appreciate that. As last year, our sponsored legislation that did pass through this committee and through the body is now in law, setting up a rare disease advisory council for the state for the very first time. And that's been working on a lot of the important issues that you cite. I think that the oppositional testimony, though, from the Michael J. Fox Association, the Maryland Association of Clinical Oncology, really are focused on Parkinson's and also on certain types of cancer, that there are concerns that the process that the PDAB goes through would affect the availability of certain drugs, particularly when it pertains to Parkinson's and cancer, that might affect the ability of those patients to access those drugs.
So if I could just request clarification, Senator, do you think they're saying that suddenly the drug will no longer be available, the drugs that are on the market now will no longer be available, or there will be no more new drugs made?
I don't think it's that they would have no more new drugs made. I think it would affect the availability, that a lot of times when it comes to these two, well, Parkinson's and the conditions of cancer, there's many different types, obviously, that it's oftentimes a tailored decision between that oncologist and that patient. And there's some nuances there that might not be as easily, discerned just by kind of cost, right? And so being able to factor that in and understand, making sure that the availability of those medications still is, there for these patients that need that is really important for those clinical decisions that are being made.
So, and that would be because a manufacturer would boycott the state, right? I mean, that's the only situation in which that would happen, isn't it? That I can think of. Because the board has absolutely no authority in clinical decision-making. They're focused on affordability, not the value of the product. They are not stepping in the shoes of a doctor or the plan's medical director or a patient. So how it gets used and when it gets used is none of their business. So I can't, the only other angle to look at this is if the board is making decisions about who gets the drug, like how sick you have to be or something, but that's not what they're going to be doing.
Mm-hmm. Okay. Well, I think there's just a careful balance that needs to be looked at here, especially, kind of as we were referencing earlier, the board really has very limited tools to go after a payer or a carrier directly in this instance. So just something to keep in mind. Thank you.
Thank you, Senator. And Senator Reedy?
Thank you, Madam Chair. Just one question that I'm looking through a lot of this, and I actually wasn't on the committee when we set up this board originally. So in the legislation, you mentioned, I think it was Jane, you mentioned pharmacies earlier, may have been in the testimony from the sponsor. Is there anything in the legislation here that would make sure that we don't set rates below what a pharmacy can be reimbursed for? Because there's a concern, you mentioned the rural pharmacies in Colorado. I've seen the same stories that my colleague has said. What is there anything that could protect against that?
I think you may be referring to the favorable with amendments, the suggested amendment that was provided by Kaiser. Is that what you're
I'm
suggesting?
actually not referring to that, but I will look
Okay.
at that. But I think there's some other folks who are concerned about this issue too, on the pharmacy side.
Mhm. I'm sorry.
So could I just ask a clarifying question, which is the concern is that the UPL is going to be, they're going to get shorted, right? It's going to cost them more to buy the product than the
Because-
UPL is going to pay.
Because as I know you're familiar
But
with,
that's-
in this committee, we have a lot of discussion about PBM, that the good, the bad, and whatever with PBMs, and there's a lot of opinions and thoughts about that. But, one of the complaints that a lot of the independent pharmacies have is that they get in these situations where they have to deal with a PBM plan and they're having to sell drugs at very
Right.
close to where they may not even make a profit on it. And unlike a CVS or some of these others, they don't sell chips and sodas as much, so they don't just want to get them into their store. So if we go to a this is pretty far reaching to say now that pretty much any drug could be capped. Is there anything, what can we do to make sure that doesn't happen? Because we don't want anywhere in the supply chain being damaged. I think
Absolutely.
the underpinning of this bill is that these companies that create these products are making record profits, and so they should give away more of those profits. And so if that's the case, we want to be sure nobody's being penalized in the system.
Exactly. So I tend to think of a UPL as just sort of a reset. So the whole supply chain starts up here with the list price of the drug, the wholesale acquisition cost. And then people buy from the manufacturer, they get a discount from the manufacturer, wholesalers do for, buying in huge volume.
Sure.
And then the wholesaler has, enough space for the next sale to give them a discount off of list price all the way down. So that by the time it gets to the pharmacy, a lot of those discounts are used up and it's pretty close to list price, right? What they have to purchase it for. Independents, CVS, Walgreens, they got their own wholesalers.
Right.
They don't have the same problem.
Which I'm not attacking them, by the way. when
No,
I
no,
say
no.
that.
And I'm just, so that's a little different for them, but for independents, by the time they get it, it's pretty close to list price. And then the PBM is trying to do national wholesale or, national acquisition cost averages, and independents get underpaid every time, right? Almost every time. That's why they go out of business. And so with a UPL, you know what they bought it for, the upper limit. Hopefully they have a little 1 or 2% discount before they got there. But if they're being reimbursed at the UPL, they're not losing money.
But there's nothing in the bill that guarantees they'd be reimbursed at the UPL, right?
Not here. In other states, it is. There's
Okay.
actually a specific provision that says independent pharmacies, not all pharmacies, independents cannot be reimbursed less than the UPL.
Okay. Thank you. Thank you, Madam Chair.
Thank you, Senator. Do I have any other questions for this panel? Thank you very much.
Thank you, Madam
and
Chair.
Thank you. We're going to
you.
bring up panel number 2, which is Baltimore Mayor Brendan Scott, Howard County Executive Calvin Ball, Montgomery County Executive Mark Elrich, Baltimore County Executive Johnny Olszewski Jr., and Dr. Martin Levy, Prince George's County Health Officer. And you can begin as soon as you're settled.
Guys, we'll just go down the line.
I just want to thank all of you for being here too. I know you have really busy schedules and I appreciate it. Who wants to start?
Chair, you first. All right, I think the mayor has nominated me to go first, Madam Chair, so we'll kick things off. Thank you so much, Chair Vidal, Vice Chair Klausmeyer, members of the committee. Thank you to Senator Guile for being our sponsor of this legislation. It is a pleasure to join you to advocate on behalf of this legislation alongside my partners in local government. Just a quick local perspective. 1 out of every 4 residents of Baltimore County is age 60 or older. And we are seeing firsthand how the rising costs of prescription drugs can defray the retirement, disrupt the quality of lives that we all agree all of our residents deserve. That's why we're here making it a priority to ensure that high cost drugs are affordable to all residents. We do think the Maryland Prescription Drug Affordability Board has been a huge help in terms of studying the rising costs of medications, working diligently to make these more affordable. Today, we're here to urge the committee to take those next steps and provide that authority for the upper limits on costs. Again, we want to thank this committee for the amazing work you've already done, and we urge a favorable report on this legislation. Thank you so much.
Thank you, County Executive. Who wants to go next? County Executive Ball, thank you.
Good afternoon, Madam Chair, Madam Vice Chair, and esteemed members of the committee. I'm honored to be here and joined by my colleagues and supporters around the state. I'm here to express my strong support for Senate Bill 388, lowering prescription drug costs for all Marylanders Act of 2024. I also commend Senator Guile and all the co-sponsors for their work on this initiative. This bill before you would guarantee that all Marylanders can afford access to needed prescriptions. In 2019, the General Assembly passed legislation creating the Prescription Drug Affordability Board. This was the first of its kind in the nation, meant to negotiate prescription drug prices for county and state government employees. More than 45% of Maryland residents are struggling to pay for necessary and sometimes life-saving medications, and Howard County has one of the fastest growing older populations in the state. I'm proud to stand in partnership, and I know that we will stand up for the well-being of Marylanders, for their lives and their quality of life, and I'm respectfully asking that you support Senate Bill 388. Thank you.
Thank you, County Executive. How about next we have Baltimore Mayor Brandon Scott.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. I am here alongside my colleagues in support of Senate Bill 388. Older adults in the city of Baltimore are more than twice as likely to live below the poverty line as their counterparts in other jurisdictions. They're also significantly more likely to have a disability, including one that affects mobility, vision, or self-care. This board and this General Assembly created the Maryland's first prescription drug affordability board, which is working to tackle these issues. But we have to take this a step further. This is a widespread issue with over half of Marylanders are concerned with the prices of prescription drugs. Baltimoreans have made it very clear that it's an important issue to them. And I will say to you what was said to me. In 2022, an attendee of our city's prescription affordability forum shared his story, struggling to balance living expenses and hospital prescription bills he incurred after being diagnosed with cancer. Another making a decision on whether he could afford the $909 per pill, a cost of his prescription, balancing his other bills. That is the reason why I am here urging a respectful support of this legislation. Thank you.
Thank you, Mayor, and Montgomery County Executive Mark Elridge.
So thank you, Madam Chair, Madam Vice Chair. I'm here to support this as well. Like everybody else, we've got an aging senior population, growing senior population in our county. I personally know people who make choices about whether or not they can actually take the prescription that the doctor has prescribed for them, because if they're in the wrong formulary, which is a different problem, they're out of luck. I know people who travel to South America to buy drugs down there, and it is cheaper to buy them down there and come back here, and to fly round trip than it is to buy them here. It's a long way to go to get the drugs you need. I think it's important that we do this. I know as a county executive and looking at our budgets, a lot of what we do, particularly in the healthcare space, is driven by rising drug costs. So anything you can do will not only help the individuals we're trying to help in the state to make sure that no one is doing without the medicine they need, but it helps all of us who are trying to manage systems with scarce resources to make sure we're not spending more on something than we need to, so we can put those resources in other places. And I respectfully request a favorable report.
Thank you, County Executive. And finally, Dr. Levy.
Madam Chair, Madam Vice Chair, Senator Guile, and members of the Finance Committee, thank you for the opportunity to provide testimony today. I'm the Prince George's County Health Officer, Dr. Matt Levy, and I'm here on behalf of Prince George's County Executive Angela Alsobrooks to express our support for Senate Bill 388. Ensuring access to quality healthcare has always been a top priority for the Alsobrooks administration. With half of the population taking at least one prescription drug, affordability is critical to achieving equitable access. This becomes even more important as we age, with 9 out of 10 seniors in the United States taking at least one prescription drug. In 2022, residents of Prince George's County identified the cost of prescription drugs as one of the 3 key barriers to receiving adequate care for families. Without regulation, critical life-saving medications like insulin and EpiPens will continue to increase in price, creating significant barriers to access for all Maryland residents. County Executive Alsobrooks commends the bill sponsors for their work on this critically important legislation and urge a favorable vote. Thank you very much for your time.
Thank you all very much. And thank you for adhering to the 1 minute. I really appreciate it. I'm sure you would like to have said a lot more, but I appreciate your time. Do you have any questions for this panel? I don't see any questions. Thank you, gentlemen.
Thank you. Thank you.
Thank you.
Next, we have panel three. Larry Zarzeki, Rosalind Berkowitz, Reverend Dr. Sandra Connor, and Lawrence Diggs. And you can start as soon as you're seated. No special order. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Rosalind Berkowitz, and I'm here today to urge your support for House Bill 388. I am the Vice Chair of the Baltimore County Commission for Women and a retired nurse. Being able to afford medications that are prescribed to them is a real struggle for many residents in Maryland. My daughter has severe ADHD, and she has been off her Adderall for over a year now. She has tried the available generics with no relief, so she stopped taking her medication. Even her psychiatrist agrees that the generics do not have the same effect. To buy the brand medication would cost her $700 a month, and that's even if it's available, which is another problem. She's unable to work and has become a recluse. No parent should have to watch their child suffer like this. I also worked in the ER for 18 years, and many patients were repeat visitors to the ER because they were rationing their insulin because they couldn't afford it. And I'm out of time, so I'll stop. I want to thank you and urge a favorable report for Senate Bill 388. Thank you.
Ms. Berkowitz, next.
Good afternoon, Madam Chairperson, Vice Chairperson. My name is Lawrence Diggs. I am a member of the Caucus of African American Leaders of Maryland. We are involved with 24 municipal county jurisdictions throughout the state. I appear before you today as a member of the Caucus of African American Leaders of Maryland in support of Senate Bill 388, which is intended to expand the authority of the Prescription Drug Affordability Board to make high-cost prescription drugs affordable to all Marylanders. As a senior citizen and as a survivor of COVID-19, which I contracted on March 23rd, 2020 while in New York, I'm thankful and grateful to be alive and before you today. I was not expected to get through that plague. Over the past 4 years, I've been treated for multiple ailments, some of which I'm currently under treatment. Significant among those is permanent damage to one of my lungs. I was prescribed Advair 250 discus by my doctor, which I have been using twice daily over 4 years. The cost for 1 month monthly prescription is $475 or $5700 annually without a drug plan. The annualized cost with Medicare and a supplemental Medicare program was $2,100. There will come a time when I may not be able to afford an Advair discus if there is a price increase, which will result in a financial hardship for me. Currently, prescription drugs prices generally are causing hardships for all citizens across the board. There are thousands of Maryland senior citizens who are suffering with absurdly high prescription drug costs, for which some will have to make a choice whether to compromise their budget, their food budget and dietary planning, and pay the high cost of prescription drugs. I might be one of them soon. Existing and future drug price increases by billion-dollar drug companies like GlaxoSmithKline will ultimately cause the demise of those of us who rely on daily prescription drugs for our mere existence. Therefore, we strongly and wholeheartedly support HB 380, known as the Prescription Drug Affordability Board, and we strongly urge the passage, and we would look forward to a report from you. Thank you very much.
Thank you, Mr. Diggs. Larry?
Good afternoon, Madam Chair, Madam Vice Chair. less than an ounce. My cost, $786.37. Less than an ounce. How many of us have family? How many of us, like me, are making decisions whether to eat, or treat a condition like I have that's neurodegenerative and there's no cure? The board has been working. I cannot echo strongly enough and loudly enough Senator Giles' opening statement. I can't afford this. I can't tell you how many times I've gone into a pharmacy and listened to a person in front of me say, "How much is this? Are you kidding me? I can't afford it. Put it back." I would like this committee to consider a favorable decision on expanding what's been started with the Prescription Affordability Board. We're just looking for stability. Thank you.
Hi, my name is Reverend Dr. Sandra Connor. I'm the president of the Baptist Ministers Night Conference of Baltimore and Vicinity. I come here, first of all, just to say for me, my overall desire is that we all enjoy good health, and that as our soul prospers, so does everything about our lives. That means that we have quality health, quality financial, quality everything that there is. But our health and our finances are often impacted because of high cost of prescription drugs. Just as the testimony coming from Mr. Larry Zdzinski today, I had an opportunity to talk to a young lady that's here today to talk about the fact that the high cost of prescription drugs has impacted her in more ways than one. She began to tear up, and as a result of that, I felt her pain. And it's often what I feel when I'm dealing with my constituents and my members of my church. They suffer in more ways than one. She's now also dealing with stress and other issues as a result of high cost of prescription drugs. I encourage you all and urge you all to please continue the work of these prescription drug affordability. Thank you.
Thank you very much. Do I have any questions for this panel? I don't see any questions. Thank you all very much. We're going to go to panel number 4. These are our faith leaders: Steve Buckingham, Reverend Ken Phelps, Reverend Lee Hudson, Reverend Dr. Cleveland Mason, and Reverend Freeman Palmer.
While the others are coming up, may I start here?
Absolutely, and I
Vice Chair.
appreciate that.
Senator Giles. I'm Steve Buckingham, a lay community minister with Unitarian Universalist Legislative Ministry of Maryland. We've been involved with healthcare for many, many years, as some of the members of this committee can testify. I've submitted written testimony. I won't repeat any of that. The important thing that I wanted to say, and this is after hearing the testimony of others, is healthcare is a right. We should all have the right to have good, affordable, quality health care. And the current board is limited in what it can do. It may be able to save state and local governments some money, but until we expand it to the greater population of Marylanders, you're not going to get into that percentage copays and deductibles where the patients themselves start to see the benefit of the lower costs. And for that reason, we ask for a favorable report. Thank you.
Madam Chair, Madam Co-Chair, thank you for this opportunity. My name is Ken Phelps. I'm the co-director of the Maryland Episcopal Public Policy Network. You have my written testimony. I not only represent our bishops and the diocesan parishes of Maryland, I also represent the Episcopal Church on this one, who 2 or 3 times in resolutions have declared, as my esteemed colleague here mentioned, that healthcare is a basic human right, along with other necessities like housing, education, nutrition. And our corporate sin is that we have commodified this to the point where, again, and our parishes deal with this every day, with people who cannot afford all of those necessities. And we do the best that we can to help, with this one or that one. My bottom line message is simple, though. It's that as people of faith, and by faith, I don't mean that we believe in some particular doctrine. It means that we trust, and that we trust that the loving thing to do is going to prove to be the right thing to do. And we are here as the Episcopal Diocese, the Episcopal Church, to ask you to please do the right thing. We ask a favorable opinion.
Madam Chair, members of the committee, my name is Lee Hudson. I am the assistant to the Bishop of the Delaware Maryland Synod in the Evangelical Lutheran Church in America for public policy. You also have our written, like my colleague Ken, out of gratitude for the blessings of life. In 2003, we committed ourselves to gaining access to appropriate and adequate health care for all people in the United States. You have already heard how our parishioners, your constituents, working people here in Maryland, can't afford their medicine, which we take to mean they are being denied access to appropriate care. And so for that reason, we're here to support SB 388 as well. Thank you.
Madam Chair and Vice Chair, Committee, thank you for this opportunity to address you today. My name is Cleveland Mason. I serve as senior pastor of the historic Perkins Square Baptist Church in West Baltimore, and I am immediate past president for the United Baptist Missionary Convention and Auxiliaries for the state of Maryland. I am here today to call attention to a quality of life issue. We need affordable prescription drugs for our people. As a pastor in Baltimore City, I witnessed firsthand the struggles of our people to have affordable prescription drugs. We struggle to get them to the doctor, and they struggle to get their medications because they cannot afford them. Today, we cannot afford to be ghosted by our government. Please pass this reasonable legislation for affordable prescription drugs. Why is our nation paying 3 times more than other countries?
Good afternoon, Madam Chair, Madam Vice Chair, and members of the Finance Committee. I'm the Reverend Freeman Palmer, and I am Conference Minister for the Central Atlantic Conference of the United Church of Christ. We have 60 congregations in the state of Maryland. We are called by Christ to love our neighbors as ourselves and to care for the sick and the vulnerable. People, we believe, should not have to choose between life-sustaining medications and essentials such as food, rent, and utilities. Our faith calls us to advocate for policies and systems that make healthcare affordable, enables a just and equitable allocation of resources, and prioritizes the well-being of people over profits. For these reasons, I encourage your support of Senate Bill 388. Your support will make Maryland a state where the health and dignity of all people are upheld. Thank you.
Thank you all very much. Appreciate your testimony. Do I have any questions for this panel? No questions. Thank you very much. Our next panel is 4 people: Vincent DeMarco, Jim Gutman, Ricara Jones, and Jishani and Raventheron. I think I said that right. I tried.
Thank you, Madam Chair. My name is Vinny DeMarco. I'm president of the Maryland Healthcare for All Coalition. Congratulations to this committee and the Maryland General Assembly for enacting the first ever Prescription Drug Affordability Board law in 2019. That has been a great success with this board that's doing a wonderful job, and we believe soon will make high-cost drugs more affordable for state and local governments. 3 states, Colorado, Minnesota, and Washington, based on the Maryland model, have passed legislation authorizing boards to make high-cost drugs more affordable for all their citizens. Through this legislation, and we thank Senator Guile very much for introducing it and all the co-sponsors, including yourself, Madam Chair, for supporting it, that this legislation will allow the Prescription Drug Affordability Board to make high-cost drugs more affordable for everyone. Drugs don't work if people can't afford them. People, as you heard earlier, can't afford their drugs. We all suffer a prescription drug tax because so much of insurance premiums are caused by high-cost drugs, as the testimony from the Maryland Health Benefit Exchange showed that's in your record. So for all these reasons, we urge passage of Senate Bill 388. Thank you.
Very well done, Vinny. Thank you.
Good afternoon, Chair Bidle and members of the committee. I'm Jim Gutman. I'm lead healthcare advocacy volunteer for the AARP Maryland. I'm also a member of the Stakeholder Council of the Maryland Prescription Drug Affordability Board. I'm here on behalf of AARP Maryland and its 850,000 members in asking you to support this bill, and we thank Senator Guile for introducing it. As Vinnie just mentioned, this is the right time to make this kind of an expansion. Not only is it needed, and you've heard this documented by so many witnesses, but there are also all kinds of protections in this bill so that it is done right. Aside from the quality of the board itself, this bill retains the role of the General Assembly's Legislative Policy Committee in overseeing the expansion. UPLs could be suspended or altered under the Maryland legislation if a drug gets on the FDA shortage list. So a lot of these supply issues that I've mentioned really should not be an issue here. And this also, thank you.
Good afternoon, members of the committee, Chair Bidel. My name is Ricard Jones. I'm the political director with 1199 SEIU. We are the largest healthcare union in the country, representing over 400,000 healthcare workers across the East Coast. We strongly support this bill to continue lowering prescription drug costs to residents. As healthcare workers, we recognize that prescriptions do little good if patients can't afford them. Some of our members have overheard patients discuss pooling money so they can purchase and then share much needed prescriptions because they can't afford to purchase them on their own. Our members provide high quality care, but it's limits to that care if their patients can't afford to purchase the medications that they need. Expensive prescription drugs place an unsustainable burden on our healthcare system. For these reasons, we urge a favorable report. Thank you.
Good afternoon, Madam Chair and members of the Finance Committee. My name is Deshawn Ravindran. I'm a researcher with the Access to Medicines program at Public Citizen. We represent over 503,000 people nationally, and we fight for greater consumer protections and affordable access to medicines. As you've heard from so many others today, there is a drug pricing crisis. And the pharmaceutical industry is going to claim that if you try to make drugs more affordable, you're going to restrict their capacity to innovate new medicines. That claim is flawed for several reasons, and I'm just going to highlight one. We authored a report this year with Protect Our Care that found the manufacturers of these drugs spend way more padding the lining of their shareholders and executives compared to research and development. If we look at the 10 costliest drugs in Maryland, according to the payers, we find that the drug manufacturers spent $9 billion more on dividends to their shareholders, share buybacks, and executive compensation compared to research and development in 2022. If you included advertising figures, that goes up to $19 billion. So these claims are flawed, and we urge you to pass this bill.
Thank you. I have one question, Senator Hershey.
Thank you, Madam Chair. Vinnie, question for you real quick. There's been a lot of conversation, a lot of statements made about the ability to save costs for seniors. But seniors are covered through Medicare, correct? So does this bill not affect seniors?
Well, this bill affects the whole upper payment limit, the whole supply chain, which could impact seniors. But seniors, as you know, are benefiting from President Biden's Inflation Reduction Act, so that all seniors, as of January 1, 2025, have a $2,000 per year cap on what they could pay out of pocket. So really, this law is more important for people not on Medicare. That's why we need it. Okay. And before I forgot to thank Senator Klausmeier, the lead sponsor in 2019, in my 1 minute. Thank you, Senator.
Okay, so this bill doesn't affect seniors, right?
It's primarily for people not on Medicare, because people on Medicare are benefiting from the Inflation Reduction Act. The rest of us need this bill.
Right. Okay. I just heard a lot of comments about, seniors and how this was going to help out, but we're in agreement. This doesn't do anything for seniors. Right.
Well, I didn't say that.
You didn't say it that. You didn't say it that way because you represent healthcare for all, so you scaled back. Let me ask another question. There's been a lot of comments and questions about out-of-pocket expenses. And, again, as we've looked at this forward, is it your motivation to make sure out-of-pocket expenses go down? Or are you just supportive of this, knowing that it will lower costs for state and local governments?
Well, first of all, I want to make clear you asked earlier about, you were comparing this bill to the present law. The present law, as Andy said, Dr. Andrew York says, is for state and local governments.
Correct.
Senator Giles' bill is beyond state
Expansive.
and local government.
Right.
So I want to make that clear. You're trying to say the new bill would only be state and local government. The new bill authorizes the board to put an upper payment limit for everyone. And there are three ways in which that will help Marylanders. Number one, according to polling that we took, is supported by many others, there are 45% of Marylanders who have the problems you heard in the previous panel. They just can't afford their drugs. For them, this law will help put an upper payment limit on what they pay for high-cost drugs. And some of it will be people who are uninsured and don't have any insurance coverage, and this upper payment limit will help them in a way that they're just not being helped right now. People who have insurance, who have high copays, as Jane Horvath said so well, your copay will go down if the amount that the insurance company pays for the drug is significantly lower. Your percentage goes down of your coinsurance and your copay. So they will be helped also. So there are people right now, as you heard in the previous panel, who are being hurt by high-cost drugs. This law will help them. In addition, Senator, all of us pay what we like to call a prescription drug tax. You have testimony from the Health Benefit Exchange, and Johanna Fabian-Marks couldn't be here today, but you have written testimony from the exchange saying that 1/3 of their premium costs is high-cost drugs. And CareFirst has said the same thing. 1/3 of their premium costs are high-cost drugs. So that is putting a burden on all of us by making our premiums higher. That's the third way that an upper payment, by reducing what the insurance companies pay for these high-cost drugs, it will put less pressure on our premiums. And third, you heard the health officer of Prince George's County talk about how local governments have trouble affording naloxone, EpiPens, and other drugs that they need because they're too expensive. And I remember our hero, Elijah Cummings, grilled the president of EpiPens and asked him why he was making 1,000% increase in those drugs. And his response was, because I can. Well, what you said in 2019, and I hope you'll reaffirm and strengthen here, is that in Maryland, they cannot.
So you mentioned it would apply less pressure to premiums, right?
Yes.
And so who saves money if premiums are lower?
Premium payers, you and I, all of us.
Premium payers? Okay.
Yes.
And so you believe that by going with upper payment limits, the premiums will be lowered?
Well, there's a medical loss ratio. I'm sorry.
Because there's other players involved in how premiums are determined, right? It's not just the pharmaceutical companies, right? We have the pharmacy benefit managers and the insurance companies themselves. And I haven't checked it, but are the PBMs and insurance companies in favor of this bill?
They're all neutral, as far as I know.
They're all neutral.
Kaiser put in a proposed amendment, but everyone else, PBMs, in 2019, all the PBMs were neutral.
So would you think that this then doesn't affect them if they're neutral, or are they willing to
I
give
don't
up
know
profits?
why they're neutral. You have to ask them that question, but I do believe that an upper payment limit would benefit all of us, from everybody who's making more on drugs. And I want to emphasize on the premiums, there's always been a medical loss ratio, but thanks to President Joe Biden, it's now stronger, so that only a certain percentage of what the insurance companies have can go into their profits and administration, and the rest has to go into healthcare. So through the medical loss ratio, we all benefit when the insurance companies have to pay less for these drugs.
Okay, and then lastly, you would like at least want to make sure, I mean, I think if I'm getting this correctly, the movement that you have and what your coalition is looking to do it is trying to guarantee that patient out-of-pocket expenses are lower. Is that right?
We believe that will be a result of an upper payment limit that reduces what everybody pays for high-cost drugs. We believe in all the ways I described, patients will be paying less and all of us will be paying less.
Okay. All right. Thank you very much. Thank you, Madam Chair.
Thank you, Senator. Senator Kyle.
Thank you, Madam Chair. Vinny or the rest of the panel, there was a question earlier regarding some of the opposition that was submitted, including by the Michael J. Fox Foundation. And I wonder, and I think some of the concern that was raised is I think that like how the expansion of the Prescription Drug Affordability Board's authority would impact things like research development and other things. Perhaps you could respond to some of the concerns that were raised in that opposition, and why I think that research and development will not be impacted, and you would agree. with
Well,
that.
I'll just start and others can join in. Certainly, I think the public citizen report that Jashawn talked about is the key here. In 2022, these 10 prescription drug companies that were a part of the Medicare negotiation spent $22 billion more in that 1 year on profits, stock buybacks, and advertising than on research. And in addition, pharma was reported recently to spend $500,000 to pay for election deniers. That's how they're spending a lot of their money. They could be putting that into research. Instead, they want to charge these high prices so people can't afford their drugs. We have to do what we can in Maryland. And I want to commend Senator Chris Van Hollen, who's put in testimony in support of this bill. He has put in national legislation called the We Paid Act, which points out that the vast majority of the research is paid for by the federal government. And his statute, his bill would become law, would say, if that's the case, the pharma can't charge whatever they want. They got to go through something like a prescription drug affordability board. So the fact of the matter is they have putting this money elsewhere, not into research, and we need to make our big people be able to afford their drugs.
All right, thank you. Thank you, Madam Chair.
Thank you. Any other questions, Senator Motz?
Thank you, Madam Chair. And Mr. DeMarco, how many drugs, say if this were to become law, how many drugs do you think would be covered by the UPL? Like 10, 15, 5?
It's an excellent question, probably just a few at the beginning. And that's a better question for Andy. But I know they identify 10 drugs that are very, very expensive in Maryland. There's also 10 drugs that the federal government identified for negotiation. But I do not envision them beginning this process more than a very few number of drugs.
About 10 drugs. How many drugs are there? Do we know?
A lot, hundreds of thousands. We would hope that they would address the most unaffordable drugs first, and then every year address more drugs. That's what we would hope.
Thank you. So it's about, so you would guesstimate to be about 10 drugs once this would be to up and running.
At the last meeting of the PDAB, they talked about their procedures for UPL. And the idea was that initially they're going to look at have each member of 5 members of the board submit a list of 4 drugs. And out of that 20, they're going to whittle it down to about 10 and go further. So they're going to start with a very small number of drugs.
Thank you.
Thank you, Senator. And Senator Hershey, again.
Thank you, Madam Chair. And I appreciate being able to ask another question, but just because you brought up the Public Citizens Report that did an evaluation of executive compensation, stock prices, buybacks, and everything for the manufacturers. Is that right?
I think you should ask John those questions.
I'm sorry. You brought it up, so I did.
Yeah. Sorry,
okay.
John wrote it.
Yeah.
Hey, oh, we have the author. Thank you.
Yeah, the author of the report.
Don't
Sorry.
need you, Vinny. How about you, Sean?
Nice to meet you as well.
Thanks. Your report then, it evaluated executive compensation, stock buyback, share prices for manufacturers. Is that accurate?
So it's dividends to shareholders,
Right.
stock buybacks, and executive compensation.
And then what did you find when you evaluated the pharmacy benefit managers and insurance companies?
We did not evaluate pharmacy benefit managers, but what we would say is pharmacy benefit managers are a downstream player in this. So ultimately, the list price that these companies are setting outrageous list prices for are causing these drug prices and drug spending to blow up nationally. And if you can address the rotting fish's head, then hopefully you can address the entire problem. And if you only go after the pharmacy benefit managers, that's not going to resolve the issue. We have a wealth of evidence from countries around the world that discipline the monopoly pricing power of drug companies to lower drug prices. And we are an outlier in the United States without that capability. And this bill would be one step closer to bring the benefits that are available to the residents of the entire world.
I didn't say go after only the pharmacy benefit managers, but you didn't even evaluate them, right?
No, we did not.
And so when Andrew talked about evaluating the entire drug supply chain. Obviously, pharmacy benefit managers and insurers play a vital role in the final cost, right?
They would, I believe the
And
estimate
it
is like
wasn't
30%.
important for you to look at who some of the wealthiest companies in the country are. If you look at the Fortune 500, who's at the top of these lists, companies like CVS and Scripps, and it wasn't important that you thought to evaluate to see if they are driven by share prices and executive compensation as well?
Well, again, Senator, I think the evidence to date is that they play a minor or a smaller role compared to these pharmaceutical companies that have monopoly protections from statutory exclusivities and patent protections that allow them to price drugs however they think the market will bear. And that's just code for how much they can price something without causing enough public outrage. So I think you need to be able to address the players that are at the top that are causing the huge downstream effects on spending.
Okay. And then finally, because I think there's a number of people in the room that greatly appreciate the work that the pharmaceutical companies do in creating life-saving drugs and therapeutic medicines that are able to help them. Can you quickly go over the products that PBMs and insurance companies provide?
Senator, I'm supportive of legislation that reins in the abuses of pharmaceutical benefit managers. But if we look at analogous federal legislation, the Inflation Reduction Act again, the Congressional Budget Office itself predicts that over the course of 30 years, only 1% of drugs would be impacted. And there's further research from Dr. Hasselheim that shows that 70% of new drug approvals don't have high therapeutic value. So we're talking about drugs that are on the margins that would not come to market. That's 1%.
Thank you very much. Thank you, Madam Chair.
I do want to mention to the committee that Jashawn's report is part of his testimony. It's Profits Over Patients. It's about an 18-page report. So thank you for including that.
Thank you.
I think there are no more questions for this panel. We have one more favorable panel. Crystal Parker, Paul Schwartz, and Virginia Crespo.
And I just mentioned to Senator Hershey, if you have only Medicare Part A and don't have Medicare Part D and don't have secondary insurance to cover drugs, you're not covered with drugs. My name is Paul Schwartz, State Legislation Chair for National Active and Retired Federal Employees. But more than that, I served as a government official for 3 federal agencies for almost 40 years. And I will tell you that one of the primary responsibilities of government is to protect its citizens and not ensuring affordable pricing of pharmaceuticals so that our citizens do not have to forego needed medication is an abdication of government responsibility. Now, granted, I recognize that R&D is applied only to domestic sales and not foreign sales of the same product. And no one wants to impede R&D, but as pointed out, the problem is not R&D, it is the stock buybacks, the advertising, CEO pay, and campaign donations. The need to provide the Prescription Drug Affordability Board with the authority to oversee pharmaceutical profit margins and ensure fair market value pricing of pharmaceuticals for all Marylanders is critical. I will leave you with 2 words, Martin Shkreli. Thank you.
My name is Virginia Crespo, representing the Maryland Retired School Personnel Association. Our members include teachers, administrators, counselors, librarians, custodians, bus drivers, and others who worked in the education of our Maryland students. Our health care is provided by the local boards of education, not the state or local governments. Protecting and enhancing health care is one of our highest priorities. MRSPA believes that retired school personnel should also benefit from the upper limit on the cost of prescription drugs. The pensions that have been earned by our members are modest at best and seriously lacking for too many. Our members should not have to choose between their necessary and life-changing medications or paying the mortgage, food, rent, or skipping the medication. This is the time to expand the authority of the Drug Affordability Board to all Marylanders. On behalf of the 12,000 members of MRSPA, we urge your support of Senate Bill 388.
Good afternoon, Madam Chair and members of the committee. My name is Crystal Parker, and I'm a community leader and organizer in Baltimore City. I'm also one of the healthcare task force leaders for Progressive Maryland. Today, I'm here to talk about my own story and how that illustrates the need to lower drug costs. Diagnosed with lupus at age 9, and over time, it's caused a great deal of bone loss and meant that I needed 2 kidney transplants. After my first transplant, I found out that the medication for the transplant was only going to be covered for 3 years. So at some point, I found myself after that time in a 2-month hole where I was not able to afford my medications because they cost $1,500 a month. And you can imagine that time being on my own, being devastated as a young law student who had just gone through all of the necessary qualifications to get a transplant, just to know that I may not be able to continue to save that transplant because of the high cost of medications. More recently, I was prescribed Forteo, an injectable injectable for bone loss, and it took 8 months to get it medically approved. Then I was told there was a $2,200 monthly copay. Once again, I had to wait. And then I was prescribed eventually Tymlos, which did not have a copay. So I have endured a lifetime of this. This started at age 9. I'm not now in my mid-50s. So it just doesn't affect elders. It affects everyone across the board. And so I urge you to please provide the extended authority for the medical affordability boards for their authority to increase the upper limits prices, the upper limits reductions for medicines. Thank you.
Thank you. Thank you for this panel. Do I have any questions for this panel? Senator Kramer.
Thank you, Madam Chair. Not a question. I just wanted to welcome Paul Schwartz, a constituent from back home, and thank him for being here and for his testimony.
Thank you. Thank you, Madam Chair. And just to follow up with the other panel asked how many drugs they thought might be covered by this if it were to become law. Mr. Schwartz, with your membership, do you know what the prescription use is of your members?
Our average age at North is in the upper 70s.
Okay. So do you know how many prescriptions the average person is taking?
I myself, and I'm pretty good health. I'm on 2 prescription drugs. So,
well, I don't want to give up your personal health stuff, but if you had, did you have any official? You don't have any official information?
I didn't collect that information, but I'm pretty sure, definitely sure that
multiple.
Almost all of them. Yes, I had a conference just yesterday, and the average age of that conference, they were in the high 80s.
Yeah.
So.
Yeah, that's okay. I just wanted to ask one. I wouldn't have to go on and on. She answered your question for me. Thank you.
I was gonna.
Sure. What would you want to share?
I'm out in the field regularly, and I advocate for older adults, and I'm also a COVID ambassador. So I'm in and out of the older adult buildings, knowing that they're taking at minimum 5 drugs, and they are at minimum of 5, and they are rationing those medications because they can't afford their rent. They don't get. A lot of them don't even get food stamps, so they gotta eat. They have to eat, and they have to pay their rent. And for transplant patients, you're talking about starting out 14 medications.
Okay.
So.
Thank you.
Yes.
Thank you for that information. I can welcome somebody from home. Ms. Crespo, it's nice to see you.
Good to see you, Senator.
Madam Chair, I just want to welcome Crystal Parker from the 40th District, one of our former State Central Committee members and a very active member of the community. Oh, and Senator Corey McCray would like to extend his welcome as well, Crystal.
Thank you, both of my senators.
And my son, Senator.
Thank you all for your testimony. Now we have 2 people that are favorable with amendments, Nora Hoban and Allison Taylor. You can start. I don't see Allison, so thank you.
Good afternoon, Madam Chair, Vice Chair, and committee members. I am Nora Hoban, the CEO of the Mid-Atlantic Association of Community Health Centers. I ask the committee to support Senate Bill 388 with amendments to keep the 340B drug pricing program intact. Maryland's community health centers deliver comprehensive primary health care to 340,000 Marylanders residing in all counties and jurisdictions. 87% of patients live at or below 200% of the federal poverty level, and more than 2/3 are from historically marginalized racial and ethnic groups. It is imperative that the bill language has no unintended consequences and will protect Marylanders' existing access to discounted medications and expanded wraparound services through the 340B program. Such services address barriers to care regardless of race, ethnicity, education, or income. The suggested amendment would ensure community health center patients aren't compromised and can continue to receive services. The amendment would signal that health equity matters and should be considered in all legislation. Thank you for the time.
Thank you. And you made it, Allison.
I
Thank you.
did, thank you. Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Allison Taylor on behalf of Kaiser Permanente. We're here favorable with amendment. Our amendment, I hope, will be considered clarifying related to enforcement, and I hope it'll address questions Senator Lamb had and Senator Reedy. With any transaction or exchange of drugs, there's both a buyer and a seller, and we'd like to clarify that in that transaction, it is the seller of the drug who's liable to make sure that the upper payment limit is adhered to, since they're the one that set the drugs. We see this as rolling downstream. So, between a manufacturer and a carrier, for example, it'd be on the manufacturer, but then, for a payer selling to a pharmacy or a patient, it would be liability would be on the carrier. So not trying to get out of it, but hoping that's a clarifying piece. So thanks for consideration.
Thank you, Allison. Do I have any questions for this panel? Thank you very much. Now I have 4 unfavorable, Laura Zarepnik, Brad Stewart, Dana Kaufman, and Kelly Memphis. You can begin as soon as you're ready.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. My name is Kelly Memphis. I am with the Healthcare Distribution Alliance. We are the trade association that represents the nation's wholesale pharmaceutical distributors. Wholesale distributors do not set list prices or determine what patients pay at counters, but we are the logistical backbone of the physical supply chain. So our members ensure that over 10 million pharmaceutical products are delivered to 360,000 sites of care nationwide. We are concerned that state level UPLs do not take into account the fact that drugs are sold and bought at the national level, and improperly applied could have negative access consequences. Therefore, we do think it is best that the board continue its current work, that is implemented, that's fully realized and evaluated before any actions are taken to expand that authority. We do think that's best for the stability of the physical supply chain in Maryland. And I finished in under a minute, so I hope I get extra credit. Thank you.
Thank you. Next.
Good afternoon, Madam Chairman and members of the committee. I'm Laura Srebnick with the Biotechnology Innovation Organization, otherwise known as BIO. Thank you for the opportunity to speak today in opposition to SB 388. BIO represents is the trade association that represents emerging biotech companies as well as well-established manufacturers, making the most innovative medicine and helping improve patient care. We also have affiliate here, the Maryland Tech Council, and they'll speak to you more about the industry here in Maryland, but it is thriving with over 50,000 jobs right here in Maryland. And we respectfully oppose this legislation. The PDAB that has been established in 2019 has cost millions of dollars, and as of now has not impacted any patient out-of-pocket costs. And expanding it at the moment will just expand policy that will not help patient out-of-pocket costs, because the legislation doesn't force rebates to go down to the patients and doesn't help them and won't help them with their copays. Thank you.
You're Brad?
Yes.
Yes, you start, Brad.
So, thank you, Madam Chair, Madam Vice Chair, members of the committee. Thank you for the opportunity to be here. More importantly, thank you for the service that you give to the citizens of the state of Maryland. I'm Brad Stewart. I'm the chair of the Maryland Tech Council. We represent 789 life sciences companies in the state of Maryland, life sciences and technology companies who collectively employ tens of thousands of the citizens that you represent. Personally, I've spent the last 3 decades working in the life sciences industry, running companies around the world. The last 27 years of those have been right here in Maryland, working to save people's lives and employ people here in Maryland and ship those life-saving medications and treatments around the world. Since they were brought up today, I spent a decade of my time in the orphan drug world, and another decade in the organ transplant arena, so I'm happy to discuss those. I'm in a unique position because, I'm sorry, I'm going to be maybe a little long here. I think we all wholeheartedly agree on the exact same thing. I think to a person, everyone would agree that we want to reduce the cost that patients pay for the drugs that they receive. I think the challenge is we've chosen a route that unfortunately is not achieving that. Expansion of the PDAB is not going to accomplish that, and unfortunately leaves Maryland's most vulnerable citizens at incredible risk, and more importantly, distracts this body from effective solutions which can have an immediate impact. If I can go on for 30 seconds. I want to give you an example. Last month, I went to fill a prescription of a drug no longer covered by my state of Maryland regulated insurer. The drugstore told me the prescription would cost $300. I declined to pick it up, went home, looked at the price on GoodRx. It was $24 at the exact same pharmacy. I could have also gotten it at a nearby pharmacy for $8. These are not problems the PDAB addresses or will ever address, and yet these are the problems that each and every one of your citizens face every single day. So with that, I'll thank you for the allowance of time.
Thank you. Thank you for that testimony. I'm going to start with Senator Hershey.
Thank you, Madam Chair. Kelly, your organization is a national organization, right?
Yes, sir.
And so you have also worked with other states that have moved forward with this, as our first witness was on the first panel. Can you also, I am reading your testimony, you talk a little bit about what I'd mentioned earlier about Colorado and concerns about access. Can you describe a little bit more what has happened out there and the concerns as well?
Sure. So in Colorado, we do have a position on the stakeholder council, so have been able to kind of observe a little bit of their work. And I do know that one of the attempts that they had first started to look at for setting a UPL for a drug, a lot of patients ended up coming and asking for that drug not to be considered for that UPL because they were very concerned that it would prevent them from being able to access it within the state. So I do know that this is how UPLs are applied. If they're not done well, can really have those consequences, and trying to figure out what that looks like is a process that all the state PDABs are undergoing currently.
Right. And so to your further comments, again, current law already has our board evaluating and taking a look at it, giving our board the opportunity to look at other states before going into this. Again, that would be your suggestion to stay where we are, evaluate and make a recommendation in 2 years?
Yes, sir. I do think for the stability of the supply chain, it's best to be able to evaluate what is the work that's already being done in Maryland and in other states before trying to expand the authority. Yes.
I appreciate it. Thank you very much. Thank you, Madam Chair.
Thank you. Next, we'll have Senator Lamb.
Thank you, Madam Chair. I guess this question could probably be best directed to Ms. Trebnick from Bio. So, you know, do recognize that there's a lot of concern about industry for things like PDAB, but also recognize, and we've heard from a lot of constituents, that a lot of these drugs are overpriced and really out of the ability for most average patients and consumers to be able to access, and many of them are struggling to do so. So, you know, I guess from the perspective of being able to rein in these costs, which is important, are the manufacturers also willing to take a reduction along with everyone across the board? Because I think everyone has a part in this to play, whether it's the manufacturers, the PBMs, the payers, that a lot of this cost sharing is being put on the burden of patients and consumers. We want to shift that back, and that involves everyone kind of along the step of the way taking a bit of a haircut. Are the manufacturers willing to do that too?
Yeah, I think that I would answer that the manufacturers already are in the form of rebates and helping out with copay assistance. But I think the problem is that those rebates and copay assistance are not getting to the patient. And so there's actually two pieces of legislation that are introduced in Maryland. One colloquially called Share the Savings, that forces those rebates. So they're stopping at the PBM level. And the PBMs are doing the negotiating right on behalf of the insurance with the manufacturers and getting billions of dollars in these rebates, but they're not being forced to pass that down to the patient. And the PDAB legislation, whether the original law or this expansion, doesn't have anything that would force that to happen. So if you want to help patients, tomorrow, legislation like that would help. And then there's also legislation on copay accumulators, basically allowing the patient assistance that manufacturers already provide to go towards patients' deductibles. Because what's happening is the insurance is saying they're taking the money and then not putting it towards the patient's deductible. So they still have to pay the entire deductible. So those two pieces of policy, if you want to help out-of-pocket costs for patients today, would be, the way to go and help that money that manufacturers are already giving go to the patients. I think you heard testimony earlier today that, basically acknowledging that this is not going to help the bottom line of out-of-pocket costs for patients.
So thank you for bringing up those two other bills and do support those other bills, just to be clear as well. But, if we do pass the other two bills, would the manufacturers still be willing to take a haircut on the upper payment limit?
So I answer your question. I want to fully concur with what you said. So I think one challenge is you hear the word used earlier today, list price, but that's not what anyone pays for a drug. That's what pharmacies and insurance companies use to decide what to charge a patient. In general, manufacturers of drugs take about a 40% reduction in price from the beginning that goes to PBMs, and either goes to the PBMs in the form of profits that they retain, or goes to the insurers, because most insurers base their drug pricing on a per member per month price, and they offset that risk to the pharmacy benefit manager. So I think both the bills you've mentioned, it's a lack of understanding of how these price discounts already get passed into the market, but are retained by the companies and not passed on to the consumer. So it's somehow getting that roadblock at a place where the consumers are actually charged appropriate prices for their drugs at the point of care.
Okay, so it just sounds like there's a lot of explanation there, but it's not a commitment from pharmaceutical manufacturers to be willing to take a haircut even on an upper payment limit, even with the other two bills being passed.
Let's take the words upper payment limit out of there. I'll say that today, the drug companies already significantly discount their drugs and will continue to do so. And I'll also say the example I gave you before was for a generic drug. That wasn't a manufacturer that would ever be negotiated in the instance of PDAB, and yet that was a $300 out-of-pocket expense to me, the patient.
Okay, I'll take that as a no.
Senator Kyle.
For any person on the panel, thank you very much for your testimony. There's some concern that was raised as to how much drug companies are spending on advertising and other things like executive salaries over research and development. I'm wondering, and I'm not sure if you had an opportunity to read the Public Citizen report, but I'm wondering if you could maybe respond to that or provide a little bit of insight about the concerns that are raised by how much funding money is spent on things like that.
Yeah, I think it's a very fair point. I think the other fair point that was raised is that's taking one aspect of the cost of drugs to the patients and ignoring the rest of them. So it doesn't take into account how much money CareFirst makes here in profit or how much they pay their executives. It doesn't take into account how much pharmacy benefit managers make. It doesn't take into account additionally what those companies take in discounts from drug companies and retain. So I fully agree. But I think it's also, they selectively chose to look at a group of 10 drugs that were selected by the federal government. They did not look at the entire drug industry. I've work with every day companies here in the state of Maryland that develop drugs. 80% of those companies will fail to survive. And so pre-selecting a group of companies that have made it and ignoring the 80% that fail and the costs associated with those is imperfect, but I again don't disagree with your statement.
And thank you. Just one follow-up to that. You touched upon earlier the costs that go into that drug development, but I'm also wondering how much of, federal dollars for like federal funding, like taxpayer dollars go into research and development, for developing drugs?
Well, NIH puts a tremendous amount of money into basic research, but that's not development of drugs. So if you go back and look at what the NIH does, they do basic research that look at clinical discoveries, biologic mechanisms. They partner with universities around the world to do that. They don't do clinical trials, or they do at a very low scale. So when you look at some of the early stage work, NIH and other non-government funders spend a fortune on those sorts of things. When you look at the cost of typically $1 billion to take a drug and prove that it works in human beings and is safe and can positively affect their healthcare, 90+% of those costs are borne by private institutions.
But you agree that certainly the pharma, they benefit from that research that's conducted by NIH and other federal or taxpayer dollar funded research, correct?
I'll answer your question with two different answers that are important to distinguish. One, any research they use from the federal government, they license from the federal government and pay them a licensing fee and royalties for any of that research. And two, any of that research that they don't license will not be developed into a drug to help save human lives. So either way, there's a downside to either path you choose.
Okay. All right. Well, thank you.
And I would just add that distributors don't market or research drugs, so I have nothing else to add to your question. So I just wanted to clarify, distributors are different than manufacturers. So thank you, Senator.
All right. Thank you. Thank you, Madam Chair.
Senator Kramer?
Thank you, Madam Chair. Ms. Srebnick, I'm going to ask you if you might be able to assist, since you're representing the trade association for the manufacturers. I'm following up a little bit on Senator Giles' line of questioning just now. As she asked the question, I began doing some quick Google searches, and I'm a little bit taken aback at some of what I am looking at. The good senator brought up advertising and the pharmaceutical industry spending on advertising. What I see here, and please share with me or the committee if you agree that this sounds appropriate, but in 2022, the industry spent $8.5 billion with a B dollars on advertising. Does that sound correct?
I'm not aware. I'm not sure. I don't have the numbers in front of me right now.
All right, and what I'm looking at also is that cumulatively over the past decade, it appears that the industry spent somewhere between 75 and $85 billion with a B over the past decade. Does that sound like it might be an accurate figure?
On advertising?
On advertising.
Again, I don't have the figures in front of me.
Okay. All right. Well, then let me ask you this, because the senator also mentioned about compensation for executives. So I just quickly looked that up. Does it sound like, and bear with me one moment, that in the year 2021, it would be accurate that the top 23 highest paid CEOs at pharmaceutical companies were paid salaries of between $18.5 million and $125 million to each of their CEOs. Does that sound like it might be an accurate figure to you, ma'am?
Again, I don't have the numbers in front of me. I will say that, we are the trade association for the biotech companies. So we have over 1,000 members. A lot of our member companies are the more emerging smaller biotechs. And, our affiliate here has talked about, we went about maybe 6-7 months ago now to Baltimore here in Maryland to the biopark and saw a lot of the member companies there just getting off the ground, but I'm not aware of the exact figures. Thanks.
No, and I appreciate that. And believe me, I value business and the startups. I don't think they're the ones that are going to be pulled into this legislation, which I think really is going to address a very limited, highly profitable segment of the industry. But I'm trying to get a handle on exactly what might be driving these costs. And I'm looking at this phenomenal expenditure. In fact, just as I was looking here, saw that pharma has now become the number 2 entity on spending, industry on spending on advertising, passing, in fact, the big tech companies. So I'm guessing when you're looking at $75-85 billion over a decade, that could certainly drive costs. But let me ask you one last question then, because the senator brought up advertising and compensation. I just quickly looked to see net income, not revenues, but net income. Would it sound correct that in net income for the year 2021, I don't know whether it's possible to find anything that's more recent, but in 2021 alone, the top pharmaceutical, the most profitable one for net income, $24 billion with a B dollars. Does that sound like it might be accurate? $24 billion in net income.
Again, I'm sorry, I don't have the figures in front of me. I don't want to give you any misinformation.
All right, no, thank you, and I do appreciate that. That the number 2 company had net income of $22 billion with a B dollars. And again, just going down the line, these are figures after they have spent the billions of dollars on advertising and the tens and hundreds of million dollars on executive compensation, and are still showing net income of well over $20 billion. So, but do you think that sounds like it might be realistic, a realistic figure?
I'm not sure.
Okay. All right. Well, thank you. I just wanted to pursue a little bit of what Senator Guile had brought up with you. So thank you. Thank you, Madam Chair.
Senator Reedy.
Thank you, Madam Chair. Real quickly, I was looking through the testimony from Bio and a lot of the other testimony. We had a State of the State address today, and Governor Moore was talking a lot about competitiveness and a lot about us winning the decade and trying to put ourselves in great position, all the potential we have. And one of the things we're most proud of in our state is investment in life science, bioscience. So there's a stat in here about what happens when phase 1 research with investment when we artificially cap prices. And we obviously are in a position where we're depending a lot on the bioscience industry for our private sector job growth. We're very heavily dependent on the federal government. So it's good to have this thing. Could you just talk a little bit about that and what the concern is there?
Yeah, sure. I'm happy to. And I'll just start with what you just last said. From our numbers, employment in Maryland has increased by 14% in the biotech sector, which is well outpacing the national average. And I know that this is very important to the governor with a biopark event that I was talking about earlier that we met and talked to some of the small emerging biotech companies. The governor actually attended and did a roundtable with some of the member companies. So that was, thank him for coming to that. On the numbers here that you're talking about, 57% of new products, medications are developed here in the US. And I think what is being referenced here is that if you have artificial price control, like you see in other countries, those new drugs and the employment and the economic investment that comes along with the R&D won't happen here. I think that's what this number is referencing.
Can I, just as a follow-up, we all want to see the price of everything come down, but I mean, it is true, and I was having a discussion actually in the back briefly when I stepped out, that it is true that this is not a completely free market system, right? So as much as I like to talk about the free market and letting the market decide, we know that obviously there's a lot of regulation and government involvement built into drug pricing and healthcare in general. Are there some things that we could do, because this bill may have some legs, I don't know. Seems like there's a lot of folks who want it.
You tell us.
Are there some things that, and if you need to get back to me offline, it'd be great, but are there some things we could do to try to protect that we have some limits on the limits so that we're not, I'm real concerned about artificially capping a price. Now, I know we have a board that's supposed to look at lots of factors, but if we artificially cap a price, we could have the kind of thing you're talking about with less investment, and then as a result, less good drugs developed, but also we lose out on the investment here in Maryland.
I think I understand your question. Oh, yeah, go ahead.
Yeah.
Do you mind if I jump in? So I agree with you. There are unintended consequences. I'll answer your questions. It may not be necessarily about this and that. If you look at the Inflation Reduction Act, there's a disparity in there between small molecules, pharmaceuticals, and large molecules, biologics, and that they allow 4 more years of protection for biologic drugs. In a year, we've already seen that fundamentally change the development of drugs around the world. Because of that 4-year difference in discrepancy, what 10 years from now might be a drug that you take orally to treat you for cancer has stopped being developed. Those companies now are looking to develop drugs that are delivered biologically as large proteins that are being infused in you that you'll take at a outpatient center, an inpatient center. So there are unintended consequences because these do have large effects on a very regulated, hyper complex system on who pays what for a drug and at what price and when. And so, yes, I believe there are. A couple of things. I completely agree with you that everyone wants to look at how we reduce the cost of drugs and whether that's because companies spend more money on advertising than people think they should or compensation. But I think to get back to the senator's points earlier today, this PDAB does not accomplish that. Its goal is to reduce the price that the state and local governments pay for the drugs. Not one person has yet testified or agreed that $1 of those savings will go to a consumer. No one has said that $1 less will a patient in this room pay out of their pocket as a result of this. I've heard the argument from Mr. DeMarco that maybe someday the insurers will lower their rates as a result. But there are immediate options the people in this room and the House and Senate can take to actually lower the cost that patients pay out of pocket today. Allowing pharmacy benefit managers to not, if a drug company is willing and putting money in to pay the copay for those drugs, and the pharmacy benefit manager saying, I'm not going to count that towards your deductible. That's just money I've saved, but you're still going to end up paying out of your pocket for something else. That's unacceptable. That's something you can change and have an impact on millions of patients this year as a result of legislation. In 5 years, the PDAB has had $0 of economic impact on the states of the citizens of the state. And so it's what are things that can be done now that are impactful and meaningful and help each person with the problem that they have. It's the example I gave. If 5 years ago, this body had said, we're going to contract with GoodRx and make sure that every person who walks into a pharmacy in the state of Maryland just has a paper card and says, don't charge me more than this rate, tens of millions of dollars a year would have been saved by now. There are very simple solutions to this complex problem. And I'm not disagreeing with any of you here that this is a complex problem that needs multiple layers of solutions.
Thank you very much. Thank you, Madam Chair.
Thank you, Madam Chair. Sorry, just one quick follow-up. Ms. Srebnick, I think you had mentioned earlier that certain countries that have drug payment rate setting boards that, pharmaceutical research and development have left, I believe. I don't mean to put words in your mouth, but I feel like you said something to that effect.
I just said that 57% of new drugs are developed here in the US.
Okay. But I feel, did you say something earlier that those countries that have drug payment or those that have drug payment setting boards that there's that stifles research and development, or some have left? Maybe I'm putting words in your mouth.
Yeah, I didn't say that they have left.
Okay, but you said something to this effect that 57% is here. And
That's correct.
and did you give, was there a reason that had indicated that, or some basis for that? Or you were just,
I was just responding to the question that was based off of our letter here that describes that a study found that an artificial 50% decrease in prices could reduce the number of drugs in development pipeline by as much as 24%.
okay. Is it fair to say that many of the highest grossing pharmaceutical corporations in the world, in fact, have their corporate headquarters in cost control board countries, if you know?
Do you know the answer to that?
If you don't know, it's so,
I'm just trying to go through the list in my head.
yeah,
I'd have to think about it. It's possible.
okay. Like Novo Nordisk, it's headquartered in Denmark, correct?
A relatively newer, larger company as far as size, but people like AstraZeneca are headquartered in Cambridge, UK. Pfizer's headquartered here in the United States.
Novartis, where's that headquartered?
Basel, Switzerland,
Okay, GlaxoSmithKline,
in the UK.
okay, Sanofi,
I don't know, but not in the US.
okay, Bayer,
Germany.
okay. In all those countries, if you know, they have government drug payment rate setting boards, if you know?
They generally don't. And there are some like the UK, which have something similar to that. In most foreign countries, they're essentially a single payer system where it's not necessarily a rate setting board, but the federal payer will negotiate or agree the payment prices on drugs.
Okay, but there's a negotiated rate. Okay, all right, thank you. Thank you, Madam Chair.
Thank you. Thank you all for your testimony. I missed two unfavorable, and I'm going to ask them to come up. Josh White and Sharice Richard, I think. You can each have 1 minute. Thank you.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. My name is Josh White from KO Public Affairs on behalf of the Pharmaceutical Researchers and Manufacturers of America. We believe this bill is at odds with the deliberate approach of the PDAB itself in the process that they put together. The board has continually urged caution and have yet to conclude that the UPL will lower costs to Marylanders or improve access. So proponents say that this is a very complicated and difficult process. And they say, well, at the same time, they want to plunge Maryland ahead on this bill. We believe that other approaches can be taken to lower out-of-pocket costs, and those issues can come up to this year in this committee alone on accumulator and rebate pass-through, and we urge that we look at those bills first.
Thank you, Josh. And Sharice, you're our last unfavorable.
Thank you, and pronounced it correctly. My name is Sharice Richard. I'm Senior Director of State Policy for Pharma. Since the inception of the PDAB, the industry has maintained consistent dialogue with the board as well as the staff. UPL's focus on the list price of a medication and neglects investigation into the full supply chain and those that directly impact how much a patient pays at the pharmacy counter. It is the insurer and their PBMs that decide copay amounts, drug coverages, and out-of-pocket costs for patients, not the manufacturer. It is important to note that no state with UPL authority has successfully established and implemented this government cap. And as we have seen in Colorado, there's significant patient concern regarding the process unfairly targeting rare disease patients and their access to their medications. Additionally, the Maryland PDAB recently received letters from patient groups expressing their concerns, with AI Arthritis encouraging the board to consider common insurance practices such as step therapy, copay accumulator adjustment programs, and maximizer programs when attempting to address affordability issues. The Maryland PDAB is still working to develop UPL action plan for their current patient pool. Now is not the time to expand.
I wonder if you both could submit written testimony so that we can have that in our file. I'd appreciate it. Thank you very much. Do I have any questions for this panel? Thank you. We have three people virtually. We'll start with, is Jody Hopkins on? Jody Hopkins is a favorable and she's virtual. We'll come back to Jody. Rochelle Cohen.
Good afternoon. I am Rochelle Cohen. I have a master's degree in hospital administration. I've worked for almost every hospital as an employee or consultant in the Baltimore region. I'm on Medicare Part D. In 2022, I developed serious GI issues diagnosed as SIBO, small intestinal bacterial overgrowth. There were no samples of the most effective drug on the market, so a script was sent and the cost was $2,500 for a 2-week supply. It's usually needed multiple times. I left and waited for a sample for weeks while my symptoms got worse. I'm in the process of doing that again. After more testing, I was also diagnosed with pancreatic enzyme insufficiency. Like SIBO, it is increasingly diagnosed with 5 branded non-generic drugs on the market, but no generic alternatives. I need it for a lifetime. It is life-saving. The cost for mine is $100,000 per year. Armed with my healthcare background, I had no idea what to do next, and I found myself combing the aisles of vitamin shops for these enzymes. They were cheap, but didn't work. Maryland legislators have been exemplary in passing extraordinary healthcare legislation for us, from cost regulations like DRGs to funding the first and still best shock trauma and emergency medical service system in the world. Please do it one more time. We really need this now. Thank you.
Thank you, Rochelle. And now we're waiting for Jody Hopkins. Okay, Rochelle, are there any questions for Rochelle? I don't see any questions from the committee. Thank you. And our, okay, do we have the unfavorable? Okay, so that ends the hearing for Senate Bill, how could I forget? Senate Bill 388. Thank you all for your testimony. Next, we will start the hearing on Senate Bill 487, Health Maintenance Organizations. And Senator Lamb, would you like to present? Is he here? Senator Lamb. Just give us some. Don't tempt me at 5 to 4. So Senator Lamb, I have your panel as Mr. Reginald Brown, Barbara Bricado, and Daniel Shattuck. Is that correct?
Yeah.
Okay, thank you very much.
All right, good afternoon. Thank you, Chair Vital, members of the committee, for allowing me to testify before you in support of SB 487. For the record, Clarence Lamb, Senator District 12. SB 487 aligns the law for healthcare provider reimbursements in health maintenance organizations or HMOs in the HMO market with the law for preferred provider organizations or PPOs by ensuring that there is a minimum floor on reimbursement rates. Out-of-network physicians in the PPO market are paid based on a benchmark date adjusted for inflation. This helps make sure that out-of-network physicians are paid at a fair rate by insurers. However, the current HMO law does not use the same method to calculate out-of-network physician reimbursements. The current HMO law outlines that out-of-network healthcare providers, apart from trauma physicians, may be paid at 125% of the average reimbursement that the HMO is paid for the same service in the same region and to a similar licensed provider as of January 1st in the prior calendar year. Benchmarking payments to the prior year means that healthcare provider payments may not keep pace with inflation. Additionally, tying the rate to the prior year allows carriers to manipulate their network in an attempt to drive down the average rate. SB 487 would add a benchmark date rather, certain of January 31st, 2019, inflated by the change of the Medicare Economic Index from 2019 to the current year. This aligns with the method used to calculate physician payments in the PPO law, the existing PPO law, and is the same date established in the Federal No Surprises Act. By passing this bill, we are not changing the 125% rate in the reimbursement formula. We are not changing the existing protections in place on balance billing for patients. We would be, however, creating consistency by aligning the HMO law with the existing PPO law in how out-of-network healthcare provider reimbursements are calculated. This committee has seen repeatedly concerns about emergency department wait times. There are a lot of factors that play into that issue, but one significant factor is the lack of staffing at our emergency departments, which is impacted by reimbursement rates that are not keeping up with costs. You're likely going to hear from carriers that this bill is related to negotiation between a specific set of ER physicians and Kaiser, and that we should leave this to the contract negotiation process. First, Kaiser is not the only HMO in the state, and we have heard from other emergency physicians about similar problems that are occurring with other companies. Additionally, this bill is not saying that Kaiser and providers can't negotiate over reimbursement rates. It's only saying that there should be some floor to those negotiations to work off of from, just as there is in the PPO market. So I ask the committee for a favorable report. Happy to turn over the other members of the panel and then take questions at the end.
Madam Chair, members of the committee, I'm Dan Shattuck here today on behalf of the Maryland Society of Anesthesiologists and also USA Acute Care and other providers. I just want to reiterate what Senator Lamb said. I think he gave a really good overview of what we're trying to do, and that's establish consistency and alignment between the two main non-par reimbursement methodologies in law for the HMO product, which is what this bill is about, and then the PPO product. We're trying to take a date certain, which provides consistency. It's going to provide clarity, and it's not going to be a tool for a provider to charge higher out-of-network rates. Physicians and providers do not want to be out of network. They do not want to willingly be out of network. And if they do go out of network, this bill will create a floor from which hopefully negotiations take place where the carriers will come forward with fair rates to bring in the physicians back into network. It's not intended to be a revenue stream or anything of that nature. So I know we've seen some reference to that in the testimony from the opposition. Additionally, the date that was chosen, January 31st, 2019, that's a date that's embodied in the Federal No Surprises Act. That body of law passed, I think, a couple of years ago. And with respect to Maryland, the No Surprises Act would come into play where Maryland law doesn't cover. Right now, Maryland law covers HMOs and PPOs, and it handles non-par reimbursement, protects patients from out of balance billing. Then the federal law comes into play. So the date, the reason for choosing it is it's a date that's known to all carriers across the country. It's not an arbitrary point in time, but it offers a point from which we can build a floor, elevate or inflate that rate over future years. With that, ask for a favorable report.
Good afternoon, Madam Chair, committee. My name is Dr. Reginald Brown. I'm a practicing emergency physician. I'm a board member of the Maryland chapter of the American College of Emergency Physicians. And I'm here today on behalf of the 500 plus physicians and the advanced practice practitioners in the Baltimore, Washington capital region of US Acute Care Solutions. US Acute Care Solutions mission is to care for patients. It's a really simple mission. And my colleagues and I are on the front lines. We battled through COVID over the last 3 to 4 years. US Acute Care Solutions has ventured since its inception to stay in network with many of the insurance companies and partners. However, we felt we're confident that we're in a good position with the No Surprises Act, but we have seen that insurances have stepped away from the table and forced us out of network. This is a challenge and presents challenges to the stability of our staffing through this COVID period. My own staff at Luminous Doctors Community Medical Center turned over 90% of our staff in 2 years. So we're asking for your support so that we can have stability in our profession and that we can continue to have in-network partnerships going forward. So we again urge your support for Senate Bill 487.
Madam Chairman, members of the committee, Barbara Brocato, and here in support of Senate Bill 487. And on behalf of the Maryland Psychological Association and the American Physical Therapy Association, Maryland. Maryland has a long history of trying to develop a methodology so that providers are paid reasonable rates and we can address the need for recruitment and retention here in the state of Maryland. It's complicated. We have one of the longest histories because it goes back to 1988 when the state started to try and find ways for providers not under contract to appropriately be paid. Way back then, because I was around and part of it, the Eugene Feinblatt Commission on Healthcare Financing, I was at the Department of Budget Management and I sat on that commission in 1988, 1989. It's been going on since then. Well, in 2010, this legislature passed a methodology that works, and that's in the PPO market. And our out-of-network rate at that date for hospital-based physicians, this is from the Maryland Healthcare Commission, was, I think it was 34% out of network. There was so much opposition from the insurance industry, and our predominant insurer testified that if this law passed, he would have no ability to recruit a hospital-based physician into his network. So the law passed, and it passed with a sunset. And the sunset, 5 years later, the Healthcare Commission did a study, and you know what? It went from 36 down to 17. They did a second study in 2017. It went from that 17% down to 3.6%. I called Ben Steffen this morning to see if he had updated numbers. He's putting them together now, but the latest numbers that we have are from 2017. This date certain works. Strongly ask for your support. Thank you.
Thank you. I have a question from Senator Reedy.
Thank you, Madam Chair. So the 2019 date, so does that, how does that have the effect of stabilizing? Will it stay at, I guess I'm not clear why it won't keep,
So
how it'll make sure it keeps pace.
right, so it's the 2019 date, which provides a known date. It's, like I said, not a surprise. It's embodied in the federal law. And then there'll be an inflation factor every year. It'll be inflated according to the medical economic index.
Oh, I see.
Right. So
Okay.
that way it's not going to be arbitrarily, moved down as the law currently stands, where you're just going back to the previous calendar year.
Okay. Okay. Thank you.
Senator Ellis.
Thank you, Madam Chair, and thank you for your testimony. Thank you, Senator Lamb. I have a question. I mean, always hear about in-network, out-of-network. Is it better for people, just patients, to see in-network, or I'm not sure what's the best? I mean,
Thank you, Senator. So no provider wants to go out of network. It's administratively harder for them and their patients are less happy. Providers only go out of network as, desperation because they cannot negotiate a fair contractual rate, which is why when I say our 2010 law worked, we basically erased the out of network problem, having that date certain in the formula. Thank you.
Do I have any other questions for this panel? Thank you. Thank you, Senator Lamb, for presenting. I have one more favorable, I think, Dana Kaufman.
Thank you very much. For the record, my name is Dana Kaufman. I'm here today on behalf of the Maryland Chamber of the Maryland chapter of the American College of Emergency Physicians and MedChi. We are in support of this bill. I don't want to repeat what my previous panelists said. I do want, though, to emphasize that not only does this create a date certain, but it has an inflationary factor, which I think is very important when you look at this and what was omitted from the bill when it was previously passed. I also just want to emphasize that we have heard in this General Assembly already this session about the costs for healthcare and the workforce shortages. Physician practices are not immune to that. Physician practices have the same cost issues that other areas of healthcare are experiencing as far as hiring, but the medical inflation just to order the supplies that they need to take care of. And that is not and the concern is that those costs aren't being covered in the rates that are being provided. It is also important to know that when we talk to our physicians, the two issues that we hear the most are about the utilization review process, which we think we got fixed in a bill this year. So I'm very pleased about that, but also the low payment rates in the state. There was a report done in 2020 by the Healthcare Institute that looked at the commercial rates across the country paid by insurers. Maryland was third from the bottom on the lowest commercial payment rates. We were only higher by a smidge on Delaware and Alabama. So when we are third from the bottom and the only other state that's below us is really Alabama, I think that's a problem. And so, yes, physicians would like to stay in network, but when they can't get rates that allow them to continue to provide the necessary services, they go out of network. This bill is to try to bring some consistency into the payment process. So we urge a favorable vote. Thank you.
Thank you. Do you have any questions for Ms. Kaufman? Thank you for that testimony. Tricia Swanson had to leave for class, so we have Allison Taylor unfavorable and Matthew Celentano unfavorable.
Good afternoon, Madam Chair, members of the committee. My name is Allison Taylor here on behalf of Kaiser Permanente, regretfully in opposition, but hopefully happy to be your last panel of the day. As you can see, a number of the primary proponents of this bill are emergency physicians. I want to give you some background on the consumer protections that patients have with respect to out-of-network emergency services. On the front end, the Affordable Care Act requires health plans to provide members with in-network rates, whether or not they go to an out-of-network physician. And that's the right policy because, you know, you don't always have a choice of where you're going to end up in the ER. So then the No Surprises Act on the other side prevented providers from balance billing members for that, which is also this, you know, same good policy if you don't want people to just through bad luck end up with a bigger bill than they'd need to. Our concern is that this is a backdoor around the No Surprises Act by taking the mandated out-of-network rate back before that law passed. HMOs, like Kaiser and like others, as they referenced, are already required to pay ER providers 25% above market rate. That already makes negotiations difficult, and by bringing it back before that rate makes it more difficult for us to negotiate to bring those providers in network. So, you know, our concern is that this bill would continue to pass along the higher costs of emergency care to patients by requiring HMOs to pay higher rates. And given that those rates must be actuarially sound, those costs are passed through to your constituents. So with no improvement to network or benefits. So we do request an unfavorable report. I will also say I was surprised to see the fiscal note didn't reflect the increased cost to the state of Maryland employee plan.
Madam Chair, members of the Senate Finance Committee, Matt Celentano here today on behalf of the League of Life and Health Insurers in opposition to Senate Bill 487. I think both my colleague Allison and I are speaking for Care First as well today, with Tricia having to leave earlier. This legislation would do nothing except raise costs to consumers with zero benefits to them. It won't improve care. It won't streamline coordination. It only increases rates emergency service providers can charge HMOs. The whole point of an HMO product is that a consumer accepts a narrower network with the same rich benefit structure you would get in a PPO product, but this legislation threatens that choice. As all of you know on this committee, the No Surprises Act passed Congress to prevent providers from balance billing consumers for services provided in out-of-network situations. This bill seems to want to reverse engineer that consumer protection law by indexing the reimbursement rates to 2019, prior to the enactment of the No Surprises Act. It's an end around on a significant piece of consumer protection legislation from Congress to protect unknowing patients. And the impact of this legislation will result in higher bills for consumers, increased premiums, as well as disincentivizing provider groups to join HMO networks. For all those reasons, we ask for an unfavorable report on Senate Bill 487.
Thank you. And you're our final panelist for today, but I have some questions. So if you can explain to me, let's just say I show up in an emergency room, I'm out of network. My insurance is only required to pay what it would normally pay for in-network? Is that?
No,
No.
If I can take that one. So we are required to charge patients at in-network rate, regardless of whether that physician is out of network or not. And the reason for that is, so the physician gets the out of network rate, but we have to charge the patient the in-network rate because they don't necessarily have a choice about where the ambulance took them. So that's the consumer protection on the health plan side.
I'm just trying to figure out what the physician is getting paid.
The physician is getting paid an out-of-network rate.
So that's more than the physicians in Kaiser would be getting paid?
Yeah, 25%. There's the formula in statute is 25% above the average rate, or a Medicare index rate that is usually lower. So the one that's being amended, I think, is typically the higher one.
Thank you, Allison. Senator Lamb.
Thank you, Madam Chair. I guess I'm trying to get a sense of for the fact that, you had said that it would not impact care. And I guess my concern is that if we don't have enough emergency room physicians and we're already seeing a shortage, that, this discrepancy in pay for ED physicians would impact care. Because it's going to either impact the ED wait times that we're seeing, it's going to impact access. And so, the concern is that it would impact that what the provider and the ED physician sees could impact care that's actually seen by the patient.
I'll say we're certainly concerned about workforce issues. I think Kaiser's position would be that this bill is not the appropriate mechanism to address that issue.
Okay. And as you know, ED providers are required by law to provide care regardless of ability to pay, which, I think makes sense, and unable to balance bill patients, which is fair, but that's putting a lot of pressure on the provider side of negotiation. What leverage or pressure is there on carriers to negotiate in good faith?
So thank you for that question. We got a lot of pressure before the No Surprises Act passed, where we would have provider groups come to us and say, if you don't accept our exorbitantly high rates, we will balance bill your members. And so it left us in a difficult position of trying to decide what's the lesser of two outcomes there. So, with that point of leverage gone for physician groups, I think, I haven't been involved in those negotiations, but I think that's just an interesting new wrinkle in how negotiations might take place. But I will say it's, a number of these groups too are national companies. They certainly are sophisticated negotiators with another national company like Kaiser.
Okay. And then in closing, you brought up the fiscal note earlier, and, I guess it's my interpretation of this is that there would be no cost increase to state employees on Kaiser. And so just wanted to kind of flag that as well. So.
Okay. Is that a question or just?
Just kind of clarifying what you had said earlier about the fiscal note. Okay. Thank you.
Do I have any other questions for this panel? Oh, Senator Ellis?
Thank you, Madam Chair, and thank you for your testimony. Could you discuss a little bit, like a baseline date for the HMO laws? You talk about a baseline,
As in what this bill is doing or what current law is doing?
both current and then what this bill.
Yeah, so current law indexes the out-of-network rate, as I understand it, to the average rate of the prior year, and then that's increased by 25%. And so what this bill is doing, and correct me if I get the details slightly wrong, but it's putting that, rather than indexing it to just the prior year, whatever the year that is, back to 2019, and then putting an inflationary factor on that too. So it would be in line with inflation based on what that 2019 date was.
Yeah, okay, thank you. So is it fair to say that what the new bill this current bill want to do is it's not a new concept, but it's reflected in other Maryland laws?
I did hear some of that testimony. I'm not an expert in the PPO law, so I'm not able to answer that one.
Yeah, I respect that. How about you, sir? Are you expert?
I don't think I'm an expert in anything, Senator. But I will say that one of our major challenges with this bill is that it indexes it to 2019. Well, if it wanted to be reflected with current time, why don't we index it to 2024? And the reason that it's indexed to 2019 is it's prior to the No Surprises Act, when we had their highest rates. And as I think my colleague had alluded to a little bit earlier, is that at that time in contract negotiations, they would be able to get a higher rate because they would say to us, if you're not going to agree to our terms, we're just going to balance bill your consumers. And carriers would agree to that higher term because we didn't want to see our beneficiaries get balance billed through no fault of their own.
You might not be an expert, but you're sure to answer that well.
I'm going to try.
Thank you. Thank you, Madam Chair.
Seeing no other questions, that ends the hearing for the day. And thank you very much for your testimony. And thank you, committee, for staying here and staying focused. I appreciate your work today.